Okay, today we're diving headfirst into just one of the most remarkable and honestly quite distressing medical mysteries I think we've come across. Picture this. It's a really high-stakes situation. You're a 61-year-old woman, you've got chronic illness, and you need a liver transplant, like a critical life-saving transplant.
Right.
But every time you go in, your routine urine tests for alcohol, they keep coming back positive.
And not just, slightly positive.
No, massively positive.
Yeah, and these results, they lead the medical teams to what seems like the obvious conclusion, maybe too obvious, but it's potentially devastating for her.
Which is?
That the patient must be actively hiding a serious alcohol problem, an alcohol use disorder.
And that assumption, just based on the lab slip, really slams the brakes on her getting that transplant.
Completely. It pushes her towards addiction treatment instead.
But here's the twist, the absolute core of our deep dive today. She swears she hasn't touched a drop, and she's telling the truth.
The alcohol's real, but it's being made by her own body. But not in the way we sometimes hear about, like in the gut.
No, this is different. It's happening locally, inside her bladder.
So today we're unpacking this really rare, kind of powerful medical thing called urinary auto-brewery syndrome. Some call it bladder fermentation syndrome.
Yeah, and our main source is this single, really compelling case report about this woman.
Our mission for you today is to sort of map out this condition, show you how her body basically became this accidental distillery.
And crucially, explain the specific lab signs, the red flags, that eventually, thankfully, saved her by overturning that first catastrophic diagnosis.
Okay, let's start with the stakes involved here, because, wow, they couldn't be higher.
Right.
So this patient, she's juggling two big health problems. Severe cirrhosis, her liver is failing. And this is really key. She has poorly controlled diabetes.
Okay.
So she shows up at the transplant center ready to get on the wait list, and they start the standard checks, including, alcohol monitoring. And right away, those checks seem to confirm what her previous hospital had already told her.
That she's drinking.
That her urine keeps testing positive for ethanol. And you have to remember, in this kind of high-pressure, high-stakes transplant world, clinicians are always balancing, urgency with making sure patients meet the rules.
Yeah.
Seeing a repeated positive alcohol test like that, it often just gets treated as, okay, proof positive, case closed, she's not following the abstinence rules.
And that's where the system kind of kicks in, right?
Yeah.
The rules for getting a transplant demand proven abstinence.
Exactly.
If they think you're drinking, you're basically out. Immediately disqualified. The whole system is built to be super cautious.
It is, and the authors of this case report, they really emphasize that systemic challenge. You had two different specialized transplant teams.
Jeez.
Yeah, look at these initial positive results and just say, okay, she needs addiction treatment. But what finally saved her, and what's really the big lesson here for everyone, is that the third team, they stopped. They actually asked, hang on, does this whole picture actually make sense?
Exactly. They noticed things that just didn't add up. Critical incongruences, the report calls them. So let's walk through the lab numbers, because this is where it gets really bizarre.
Okay, so the urine ethanol tests, they weren't just positive, they were screaming positive.
Like how high?
We were talking levels sometimes over 39.1 millimoles per liter.
Okay, what does that mean in terms most people understand, like mgdl?
Right, that translates to over 180 milligrams per deciliter. To give you some context, the legal driving limit in most places is 0.08%, which is about 17 millimole or 80 milligdl.
So her urine was testing at more than double the legal limit for driving impairment.
Sometimes, yes. It looked absolutely damning on paper.
Yeah, I can totally see why that initial diagnosis of, alcohol abuse felt so automatic.
Of course.
But hang on, if someone was drinking that much alcohol to get those urine levels, surely their blood would show it too. Shouldn't they be, visibly intoxicated?
That's the million-dollar question. That's the core disconnect here.
Okay.
If she'd consumed the alcohol, it would go through her stomach, her gut, get absorbed into the bloodstream, right, and circulate everywhere.
Makes sense.
But her plasma ethanol tests, the tests on her blood were consistently completely negative.
Negative, like zero.
Below the standard cutoff, which is 2.2 millimole or about 10 milligdl. So no detectable alcohol in her bloodstream whatsoever.
Okay, that's a massive contradiction right there. Huge levels in the urine, the output, but absolutely nothing in the blood, the system itself.
Exactly. But they didn't stop there. They dug even deeper. They started looking for the chemical footprints, the evidence that her body had actually processed alcohol recently.
Ah, like the breakdown products, the metabolites.
Precisely. When your liver metabolizes ethanol, it creates these specific byproducts.
What are they called?
The main ones they checked for in her urine were ethyl glucuronide, or ETG, and ethyl sulfate, ETS.
And why are they important?
Because these things hang around in the urine for quite a while, much longer than the alcohol itself. They're considered pretty definitive proof of recent drinking.
So do they find them?
Nope. Also negative.
Wow. Okay, let's recap. We've got sky-high urine alcohol,
Right.
negative blood alcohol,
Yep.
and negative metabolites that would prove she actually drank it.
Correct.
Just like finding a full bottle of expensive scotch locked inside someone's car.
Uh-huh.
But the driver passes the breathalyzer, passes the blood test,
Yeah.
shows no sign of having had a drink. It doesn't fit.
That's a great analogy. And clinically, remember, she kept denying drinking. And crucially, she showed zero signs of being drunk or even tipsy during her clinic visits, despite these supposed sky-high urine levels.
Right.
What's so fascinating, and maybe a bit alarming, is that the negative blood test and the negative metabolites should have immediately flipped a switch for the clinicians.
Yeah, away from she's hiding drinks. Towards what?
Towards thinking the alcohol must be produced after it left the bloodstream, or maybe only within the urinary system itself. Local production, in situ, as they say.
The moment they considered local production, they basically had to become detectives, right? Looking for a tiny, hidden brewery inside her body.
Pretty much. They needed to find the ingredients for fermentation right there in her bladder environment.
Okay, so what are the ingredients for brewing? You need fuel.
Right, a sugar source. And her existing condition handed it to them on a plate. Because her diabetes was so poorly controlled, she had something called hyperglycosuria.
Hyperglycosuria, meaning?
Just incredibly high levels of glucose sugar spilling into her urine. The paper mentions levels at or above 55.5 millimoles per liter.
That sounds like a lot. What's the conversion?
That's over 1,000 milligrams per deciliter. Just a massive, readily available fuel source floating around in her bladder.
Okay, so that's the sugar, the substrate. What's the other key ingredient? You need something to actually do the fermenting.
The brewer itself. And they found that too. Her urine samples were loaded with abundant budding yeast cells.
Yeast, like baking yeast.
Close. So finding the yeast plus all that sugar led them straight to the hypothesis. This yeast, living in her bladder, was feasting on the excess sugar and fermenting it, converting it directly into ethanol. Problem solved.
Hold on, though. Lots of people, especially diabetics, can get yeast infections or have yeast present, right? And many diabetics struggle with high blood sugar, which means sugar in the urine.
That's true.
So why doesn't this happen all the time? What made her specific situation turn into this, auto-brewery? Why her?
That's exactly the right question. It's not just about having yeast and sugar. You need the perfect storm.
Okay.
You likely need the right kind of yeast and probably a high concentration of it. Plus, it needs enough time in contact with the sugar at the right temperature.
So what was the specific yeast culprit here?
It was identified as Candida glabrata.
Is that unusual?
Yeah, not really. It's often part of the normal human flora, lives on our skin and mucous membranes without causing trouble usually.
Okay.
But when it gets concentrated in an environment that's super rich in its favorite food glucose, it can really take off. And here's the kicker. Candida glabrata is actually a close relative of Saccharomyces cerevisiae.
Which is?
That's the classic brewer's and baker's yeast, the one we use deliberately to make beer and bread.
No way. So she basically had a cousin of brewer's yeast.
Uh-huh.
Thriving in a sugary, warm environment, body temperature.
Exactly. It's like a textbook setup for fermentation happening unintentionally inside her bladder.
Okay, this makes the distinction really clear then between this urinary auto-brewery syndrome, UABS,
Right.
and the more, let's say, traditional auto-brewery syndrome, ABS, that people might have heard about.
Yeah. The difference is all about location and what happens next, physiologically.
Explain that.
Okay, traditional ABS, sometimes called gut fermentation syndrome, happens, as the name suggests, in the gastrointestinal tract, the gut. And because the gut's job is to absorb things into the bloodstream, the alcohol produced by yeast fermenting carbs in the gut does get absorbed.
And that's what causes the intoxication symptoms people report with traditional ABS.
Absolutely. Someone with gut fermentation ABS will actually have positive blood alcohol levels. They can feel drunk, dizzy, impaired, especially after eating a meal high in carbohydrates, because that ethanol is getting into their system.
But the bladder is different. It's mostly just for storage, isn't it? It's not really
Yeah.
designed to absorb things back into the body.
Precisely. While the bladder isn't always perfectly sterile, and colonization like this can happen, its main job is holding urine. It doesn't have efficient mechanisms to transport that locally brewed ethanol back into the bloodstream.
So that's the key difference with UABS.
That's the defining feature. Fermentation happens in the bladder, leading to those really high urine ethanol levels.
Yeah.
But because it's not absorbed systemically, the blood tests stay negative and the person generally doesn't feel intoxicated.
That just completely flips the script from the initial suspicion of alcohol abuse, doesn't it?
Totally. It shifts the focus from behavior to microbiology and endocrinology, the diabetes control.
So did they try to, like, evict the brewer? Could they treat the yeast?
They certainly tried. The standard approach would be antifungals. They gave her an oral antifungal medication regimen to try and eradicate the Candida glabrata.
And did it work?
Unfortunately, no. The case report includes a really critical and kind of somber note about that.
What happened?
The treatment was unsuccessful, and the authors specifically attributed this failure to her underlying poorly controlled diabetes.
Ah, so the fuel supply just kept coming.
Exactly. Even if the antifungal knocked back the yeast population temporarily, the constant flood of sugar into the urine created the perfect environment for it, or maybe new yeast, to just come right back and start brewing again almost immediately.
Well, that creates this really challenging medical catch-22, doesn't it?
It really does. You have the chronic disease, the diabetes, enabling this acute syndrome, the UABS,
Right.
and that UABS is threatening the treatment, the transplant, for the other major life-threatening condition, the cirrhosis. Everything's interconnected.
Okay, this is where the story gets even more interesting, almost like something out of a forensic science show. Because the initial lab results were so confusing and the stakes were life and death.
Mm-hmm.
The transplant team couldn't just rely on their hypothesis. They had to prove it scientifically.
Yeah, they essentially had to become forensic microbiologists for a day. They designed an experiment in vitro, meaning in glassware outside the body, to recreate the conditions inside her bladder and prove fermentation was happening.
Real detective work. How do they set it up?
It was quite clever. They took a freshly voided urine sample from her. Then, using a centrifuge, they spun it down to separate it into two parts. One fraction that was rich in yeast cells and another fraction that was yeast poor.
Okay, yeast-rich versus yeast-poor.
Right. And they didn't just test these once. They wanted to see if fermentation would actually happen over time and under different conditions.
Simulating different environments, like if the sample sat around.
Exactly. They incubated samples of both fractions at 3 different temperatures. One was 4 degrees Celsius, think refrigerator temperature, cold storage.
Okay.
Another at 25 degrees Celsius, which is roughly room temperature.
Right.
And the crucial one, 37 degrees Celsius, which is normal human body temperature.
Got it. Did they have a control?
Yes, very important.
Yeah.
They also treated some samples with sodium fluoride.
Why sodium fluoride?
It's a known inhibitor of fermentation. So if alcohol still increased in those samples, it wasn't due to active brewing by the yeast. This ensured they were measuring new alcohol production, not just what was already there.
Okay, the experiment is set. Yeast-rich, yeast-poor, different temperatures, plus an inhibitor control. What happened? Did the urine actually start brewing alcohol in the test tube?
The results were, well, incredibly clear and dramatic.
Yes.
Just as you'd expect, they saw minimal, practically no, new ethanol production in the yeast-poor samples.
Makes sense. No brewer.
Right. And also minimal production in the samples kept cold at 4 degrees, or in the samples treated with the sodium fluoride inhibitor.
So that confirms fermentation needs the yeast, and it needs warmth, and it can be stopped.
Precisely. But then came the key condition. The yeast-rich fraction incubated at body temperature, 37 degrees Celsius.
What happened there?
That's where the brewing just took off. Exploded, really.
How much?
The ethanol level in that specific sample started at a baseline of 9.6 millimoles per liter.
Okay, about 44 milligrams per deciliter. Still positive, but lower.
Yes. But after just 24 hours incubating at body temperature, that level climbed to a staggering 177.1 millimoles per liter.
Wow. What's that in mgdl?
That's over 800 milligrams per deciliter.
800? That's insane.
And just one day, in a test tube mimicking her body conditions, the alcohol concentration in her urine became, 7 or 8 times higher than the legal driving limit?
That's just irrefutable proof, isn't it?
Absolutely. A local distillery operating under bodily conditions, game, set, match for the diagnosis.
So the UABS diagnosis was confirmed, scientifically validated.
Mm-hmm.
And that confirmation led to the previous denial being overturned. And thankfully, the patient was reconsidered and put back on the liver transplant wait list.
Yes, a potentially life-saving outcome based on that diligent investigation. But if we pull back and connect this to the bigger picture, the authors use this case to really hold a mirror up to the medical system itself.
How so?
They talk very openly about how easily those crucial contradictory signals, the negative blood alcohol, the negative metabolites, were missed or dismissed by two separate, highly specialized liver transplant teams.
Why do they think that happened?
They point to a few things: the intense pressure of time in these clinics, the huge workloads clinicians face, and maybe just the cognitive ease of relying on a single, easily interpreted positive test result. The initial incorrect diagnosis just sort of stuck. Maybe some confirmation bias crept in.
It really highlights the need for just extreme diligence, doesn't it? Especially when a wrong interpretation isn't just an error, it's potentially life or death, like in these pre-transplant situations.
That is precisely the call to action echoing from this report. Think about how often abstinence monitoring is required, not just transplants, but addiction programs, sometimes court orders for custody, employment screenings.
Right. Lots of places.
In all those settings, if the urine test screams yes, but the blood test or the clinical picture screams no, clinicians need to be trained and, frankly, empowered to notice that discrepancy and investigate it properly. Don't just accept the simplest answer.
So what do the authors propose?
They conclude by saying that standardized guidelines are urgently needed for interpreting these often conflicting lab results in abstinence monitoring. We need clearer protocols to prevent these kinds of errors from jeopardizing patient care or even patient lives.
So wrapping up the main story, the core message feels like one of maybe scientific humility.
I think that's fair.
You have this incredibly common thing, a simple yeast, Candida glabrata. Combine it with a huge fuel source, all that sugar spilling into the urine because of poorly controlled diabetes.
What a perfect storm.
And boom, you accidentally create this localized chemical factory right inside the bladder. The positive alcohol tests it produced were biochemically real, but they were completely irrelevant to the question of her sobriety.
And the big takeaway for you, the listener, is crystal clear from this. Never just accept a single lab result at face value if the patient's story, their symptoms, or, crucially, other related tests like plasma versus urine or ethanol versus its metabolites contradict it.
You absolutely have to look at the whole picture, the full panel of evidence.
Definitely.
Okay, but this brings us back to that sort of complex, sticky loose end that was left dangling in the case report.
Yes, the treatment failure.
Right. The source material confirmed that the oral antifungal medication didn't work, specifically because her diabetes remained poorly controlled, which strongly implies that the urinary auto-brewery syndrome, even though it was diagnosed, probably just continued. It was enabled by that ongoing underlying chronic disease.
Yeah, it likely persisted as long as the conditions were right.
So this seems to raise a really difficult, maybe unresolved question for doctors evaluating transplant candidates, doesn't it?
It certainly does. It's an ethical and medical tightrope.
How so?
Well, think about it. If the underlying chronic disease, the severe diabetes in this case, is the very thing enabling the UABS,
Right.
and we also know that poorly controlled diabetes itself is often a major factor that complicates transplant outcomes and eligibility.
Okay, yeah.
Then where does the clinical responsibility really lie? Does fixing the systemic problem, getting the diabetes under much better control, have to become the absolute top priority, potentially delaying or even preventing the transplant, even after you've disproven the initial suspicion of alcohol abuse?
It's like you solve one problem, proving she's not drinking, but uncover another deeper one, the diabetes driving the syndrome, that might still be a barrier to the ultimate treatment she needs.
Exactly. It just shows how in complex medicine, the answers often lead to more complex questions. One problem is rarely isolated. It's usually tangled up with others. Something important to keep thinking about.